trying to get your head around complex medical conditions. It can feel like wading through treacle, can it?
Oh, absolutely. You pick up bits here and there, but making it all stick.
Exactly. Especially for when you really need it. That's the real challenge.
Mm-hmm.
Well, on today's deep dive, we're aiming to streamline that whole process for you. We're going to focus in, laser-like, on Prader-Willi Syndrome, PWS.
Yeah, PWS, it's a condition that really touches on so many different areas of health, development.
It really does. And you've gathered some great source material for us, your notes and so on.
Right. So think of this as us putting on our headlamps, going into that material, and pulling out the absolute must-know information.
High-yield stuff.
Precisely. The goal is a really clear, structured understanding of PWS, something you can actually recall and use. Let's make this stick.
Okay, let's do it. Straight in. What is Prader-Willi syndrome? Let's start right at the beginning.
Okay, so in simple terms, it's a rare genetic disorder. And the really crucial thing to grasp is just how wide-ranging its effects are. We're talking physical growth, cognitive abilities, even behavior.
So it's not just one thing.
Not at all. And the root cause is genetic. Specifically, it's about missing or inactive genes on the copy of chromosome 15 we get from our father.
From the paternal side. Okay. And that genetic difference kicks off a whole cascade of effects.
Exactly, a cascade throughout the body.
And this leads to some core characteristics, the ones we really need to remember.
Yes. The big one, often the most striking, is this constant, overwhelming drive to eat. Hyperphagia.
Hyperphagia.
Right.
Which, sadly, often leads to significant obesity.
It does. Then you have intellectual disabilities and a range of hormonal imbalances that are really key to the whole picture.
Okay, so hyperphagia, obesity, intellectual disability, hormonal issues. Those are the headlines.
Pretty much. But it's also useful to frame it as a neurodevelopmental disorder. Often, right back in infancy, there's hypotonia, that's low muscle tone.
Floppy baby syndrome, sometimes called.
Kind of, yeah. And that hypotonia can actually cause initial feeding problems, maybe even failure to thrive in the very early months.
Which seems counterintuitive given the later hyperphagia.
It does, doesn't it? Then, as the child develops, hormonal issues like hypogonadism, underactive sex glands, or hypogenitalism become clearer. Short stature is common, too, and often small hands and feet.
And you mentioned behavior as well. It's not just physical.
No, definitely not. There can be significant cognitive and behavioral challenges. Things like frequent temper tantrums, sometimes quite compulsive behaviors, even skin picking can be a part of the picture.
Wow. So it really is multifaceted, affecting development across the board.
It truly is. Okay, so let's maybe dig into the why now. The etiology, what causes it.
Right, the underlying causes. We know it's chromosome 15, the paternal copy.
Correct. And the most common reason in about 70% of cases is a deletion.
A deletion, so something's actually missing.
Yes, exactly. A specific bit of the paternal chromosome 15, the region called 15q11q13, is just gone, missing from the instruction manual, so to speak.
And that's the main driver for most people with PWS.
For about 70%, yes.
But it's not always deletion, is it? There are other ways this can happen.
That's right. Another major cause is something called maternal uniparental disomy, or UPD.
Okay, UPD. What's that?
So normally you get one chromosome 15 from your mom, one from your dad. With maternal UPD, you actually inherit both copies of chromosome 15 from your mother and none from your father.
Ah, I see. So you have two copies, but they're both the maternal ones, and the crucial paternal genes in that region aren't there or aren't active.
Precisely, and that accounts for a good chunk of the remaining cases. Then there are also imprinting center defects.
Imprinting center defects? Sounds complex.
It is a bit. Think of them as errors in the switches that control whether genes in that 15q11q13 region are turned on or off. The paternal genes should be on, but if the switch is faulty, they might be off.
Got it. So deletion, getting two maternal copies instead of one of each, or faulty gene switches.
Exactly. Whatever the specific mechanism, the end result is the same. The necessary genes on the paternal chromosome 15 aren't being expressed properly.
And that messes up critical functions like appetite control, growth, development, like your recipe analogy earlier. Missing ingredient, wrong amounts, broken oven.
Yeah, something like that. The final dish isn't right.
Okay. Now, what about risk factors? Does this tend to run in families?
That's a really important question. And interestingly, for most people with PWS, the genetic change happens spontaneously. De novo, we call it.
So it's usually a brand new event around conception, not inherited.
In the vast majority of cases, yes. It's not typically passed down directly from a parent.
But there are exceptions.
Very occasionally, yes. In a small percentage of cases, particularly those involving certain types of imprinting center defects, there might be a family history or a slightly increased recurrence risk, but generally it's sporadic.
Good to know. Mostly a one-off genetic event. Okay, let's get into the pathophysiology, the biological how. What's going wrong inside the body?
Well, the central player here seems to be the hypothalamus.
Ah, the brain's control center.
Exactly. A tiny but vital part of the brain regulating loads of things, including appetite. In PWS, the lack of those active paternal chromosome 15 genes messes with the hypothalamus's normal function.
Okay, so the appetite control center is faulty.
That's a good way to put it. And that's believed to be the direct cause of that relentless hyperphagia, that constant feeling of hunger. The I'm full signals just aren't working properly.
Makes sense.
And alongside that, you get these hormonal imbalances we mentioned. Growth hormone deficiency is very common.
Leading to the short stature.
Right, and affecting other things like body composition too. And then there's hypogonadism, the reduced function of the ovaries or testes, which is also tied into these hormonal disruptions originating from the hypothalamus or pituitary gland.
And you mentioned genomic imprinting earlier. PWS sounds like a classic example.
It absolutely is. It holds a really significant place in genetics because it was one of the very first human disorders recognized as being caused by imprinting.
Which is where genes behave differently depending on which parent they came from.
Exactly. For this specific region, 15q, 11q13, it's normally only the genes inherited from the father that are switched on. In PWS, because those paternal genes are missing or silenced, you don't get the proteins they're supposed to make.
And just to recap the rough percentages for the causes.
Sure. Paternal deletion is the most common, around 60–70%. Maternal UPD is next, maybe 25–35%. And then imprinting defects make up the rest, a smaller percentage.
Helpful figures to keep in mind. Okay, so when a clinician suspects PWS, what else might be on their mind? The differential diagnosis, what else looks similar?
Good question. There are definitely other conditions with overlapping features. Several other genetic syndromes need consideration.
What?
Bardet-Biedl syndrome, Cohen syndrome, Lawrence-Moon syndrome. These can also involve obesity, developmental delays, sometimes vision problems, or extra finger stows, which can overlap.
Okay, other rare syndromes. Anything more common?
Well, you'd also consider things like non-syndromic obesity, although the pattern of hyperphagia in PWS is usually quite distinct. Fragile X syndrome might be considered, especially in younger boys with developmental delay.
Right.
And then specific features like cryptorchidism, undescended tests, or short stature might initially point towards other causes before PWS is considered. There's also a condition called hyperphagic short stature syndrome, so careful assessment is needed.
Definitely sounds like it requires thorough workup. Let's switch gears slightly. Epidemiology. How common is PWS?
In the UK, the estimates are generally around 1 in 15,000 to maybe 1 in 25,000 live births.
So quite rare.
Yes, it's considered a rare disease, and importantly, it affects males and females equally, and people of all ethnic backgrounds.
And is that roughly the same worldwide?
Pretty much, yeah. Global estimates are often cited as between 1 in 10,000 and 1 in 30,000. Sometimes maybe slightly higher figures quoted, perhaps around 1 in 20,000. There's some suggestion it might be slightly more noted in Caucasian populations. But the key takeaways are, it's rare, mostly sporadic, and affects both sexes equally.
And you mentioned its significance in relation to obesity.
Yes, that's a stark point. PWS is actually the leading genetic cause of life-threatening obesity in humans.
Wow. That really drives home the importance of diagnosis and management.
It absolutely does.
Okay, so clinical features. How does PWS actually present? What do we see?
Well, a key thing is that the presentation changes quite dramatically with age. So right from birth, you might notice some subtle characteristic facial features. But the really prominent sign early on is the hypotonia, that low muscle tone.
The floppiness.
Exactly. Babies might feel floppy when held, have a weak cry, and often have trouble feeding initially because of a poor suck. This can lead to delays in hitting motor milestones, sitting up, crawling, walking.
So difficulties early on. Then what happens?
Then, usually somewhere between the ages of, say, 1 and 6 years old, often around 12–18 months, there's this switch. The feeding difficulties resolve, and this intense, insatiable appetite, the hyperphagia, kicks in.
The hallmark feature.
The hallmark feature, yes. And without really strict food management, this inevitably leads to excessive weight gain and obesity. Around this time, the short stature often becomes more apparent too, intellectual disabilities are more noticeable, and those behavioral problems start to emerge more clearly.
What kind of behavioral problems?
Things like temper tantrums, stubbornness, obsessive-compulsive behaviors, and as mentioned, sometimes skin picking. Sleep disturbances, including sleep apnea due to obesity or central causes, are also common. And the effects of hormonal imbalances, like delayed puberty, become evident.
You mentioned a specific cognitive profile earlier, too.
Yes, while there is generally an intellectual disability, individuals with PWS often show relative strengths in certain areas, like visuospatial skills, processing visual information, puzzles, that sort of thing. Recognizing these strengths can be important for education and support.
It's useful. So those two key stages are really helpful. Infancy with hypotonia and feeding issues.
Right. Sometimes even failure to thrive initially.
And then that switch to childhood hyperphagia, weight gain, developmental delays becoming clearer, behavioral issues, hormonal signs.
Exactly. That transition is really characteristic. And linked to that hyperphagia, there's often markedly high levels of a hormone called ghrelin.
The hunger hormone.
That's the one. It's thought these high ghrelin levels play a big part in that relentless drive to eat.
Really paints a clear picture. Okay, so investigations. If PWS is suspected, what tests are done?
The absolute gold standard, the essential test, is genetic testing, specifically DNA methylation analysis.
Methylation analysis, why that one?
Because it detects the specific imprint, the pattern of chemical tags on the DNA in that critical region of chromosome 15, it can pick up PWS regardless of whether it's caused by a deletion, UPD, or an imprinting defect. So it's highly sensitive.
Okay, so that's the main diagnostic test. What else?
Well, hormonal assessments are really important too, given the common issues like growth hormone deficiency and hypogonadism.
Right.
So that might involve growth hormone stimulation tests, measuring levels of sex hormones, thyroid hormones, and maybe a bone age X-ray to check skeletal maturity.
And what about development and behavior?
Absolutely. Psychological and developmental assessments are crucial to understand the individual's cognitive level, identify learning needs, assess behavior, and guide interventions.
I see. And are there like checklists,
Yeah.
diagnostic criteria?
Yes, there are established diagnostic criteria, often divided by age 1 set for birth to age 3 and another for age 3 through adulthood. They list major and minor criteria.
What are some of the major ones?
Major criteria include things like that neonatal hypotonia, the feeding problems early on followed by rapid weight gain or hyperphagia later, characteristic facial features, hypogonadism, global developmental delay, and of course the specific genetic abnormality on chromosome 15.
And minor criteria might include?
Things like decreased fetal movement during pregnancy, those typical behavioral issues, sleep problems, short stature for the family, maybe hypopigmentation, lighter skin and hair than other family members, small hands and feet. A certain combination of these supports the diagnosis.
Okay. And you mentioned Frischage earlier as well.
Yes, FH fluorescence in situ hybridization. It's another genetic technique. It uses fluorescent probes to light up specific DNA sequences. It can be used to directly detect if the 15q11q13 deletion is present.
So it confirms a deletion specifically.
Exactly. Methylation tells you if it's PWS. FASH can help tell you why, if it's a deletion. It can also help differentiate PWS from Angelman syndrome, which affects the same chromosomal region but involves the maternal copy.
Got it. And once the diagnosis is confirmed, management sounds like a huge undertaking.
It really is. It absolutely requires a multidisciplinary team. Doctors, dietitians, physios, occupational therapists, speech therapists, psychologists, educators, social workers, and crucially, the family.
What's the top priority usually?
Nutritional management is paramount. From a very early age, strict control over caloric intake is essential to try and manage the weight gain and prevent severe obesity and its health consequences. This often requires locking cupboards and fridges.
That sounds incredibly challenging for families.
It is. And then there's growth hormone therapy.
Right, for the short stature.
Yes. If growth hormone deficiency is confirmed, GH therapy can significantly improve height, but also helps with body composition, increasing muscle mass, decreasing fat mass, and can sometimes have positive effects on energy levels and development, too.
And other therapies.
Early intervention is key. Physiotherapy for the hypotonia and motor skills, speech therapy, occupational therapy for daily living skills. Special education tailored to their specific learning profile is vital. And behavioral interventions are really important for managing tantrums, compulsions, and other challenging behaviors.
Are medications used for behavior?
Sometimes. Medications like SSRIs for anxiety or obsessive behaviors, or sometimes antipsychotics like olanzapine or risperidone for more severe behavioral issues might be considered, but always cautiously and as part of a wider plan.
It really sounds like lifelong comprehensive care.
Absolutely. Regular monitoring is crucial. Checking growth, hormone levels, screening for complications like scoliosis, sleep apnea, diabetes, osteoporosis. Vision checks are important too.
And managing the transition to adulthood must be complex.
It is. Continued support is needed, often focusing on vocational training, life skills, and potentially supported living arrangements or residential care for some individuals to ensure safety and quality of life, particularly around food access.
And genetic counseling is vital for families.
Essential, especially regarding recurrence risk. As we said, for deletions and UPD, the risk of having another child with PWS is very low, usually less than 1%.
Because they're usually spontaneous events.
Exactly. But if it's caused by certain imprinting center defects, particularly inherited microdeletions, the risk can be higher, up to 50% in some specific scenarios. So knowing the exact genetic cause is important for counseling. Epigenetic mutations usually have a low risk too, less than 1%.
Really crucial information for families. Okay, prognosis. What's the long-term outlook?
It's variable, of course, and good management makes a huge difference. With comprehensive, lifelong support, many individuals with PWS can live fulfilling lives, but it is a lifelong condition requiring ongoing care.
What are the biggest lifelong challenges?
Managing the hyperphagia and obesity remains a central challenge throughout life, along with the associated health risks. Intellectual disabilities and behavioral issues require ongoing support, and managing the hormonal imbalances is also key.
And sadly, life expectancy can be affected.
Yes, unfortunately, PWS is associated with a reduced life expectancy. This is primarily due to complications arising from obesity.
Like what sort of complications?
Cardiovascular problems, respiratory failure, often linked to obesity and sometimes sleep apnea, type 2 diabetes complications, infections, sometimes gastrointestinal issues like gastric rupture from overeating.
Are there figures on life expectancy?
Studies vary, but they consistently show reduced longevity. Some estimate an increased mortality rate maybe around 3% per year compared to the general population. One study mentioned an average age of death around 30, although many live longer, especially with better management now. But premature death, often obesity-related, is a serious risk.
Yeah, it really underscores the need for vigilant care. Let's just briefly list those main complications again.
Sure. Top of the list are the obesity-related ones: type 2 diabetes, high blood pressure, heart disease, stroke risk, severe sleep apnea.
Okay, what else?
Scoliosis, curvature of the spine, is common. Osteoporosis, weak bones. Problems regulating body temperature. Gastrointestinal issues, especially constipation, can be persistent. And then the ongoing hormonal issues and the behavioral challenges we've discussed: compulsions, tantrums, anxiety.
So a wide range of potential issues to monitor.
Exactly, which highlights why that regular medical follow-up, that multidisciplinary team approach, and early intervention are all so critical. The goal is always prevention where possible and proactive management to maintain health and well-being.
This has been incredibly thorough, a real deep dive. Just to summarize the key takeaways then, PWS is this rare genetic disorder, paternal chromosome 15 abnormality, causing that switch from early hypotonia feeding issues to later childhood hyperphagia, obesity, developmental delay, distinct behaviors, and hormonal problems.
Spot on. And diagnosis relies on methylation testing primarily. Management needs that huge multidisciplinary team effort focusing on diet, GH, therapies, and behavior.
And while prognosis is lifelong, good management is key to tackling challenges like obesity and improving outcomes, though complications are a serious concern. Hopefully, breaking it down like this has made it much clearer and easier to remember.
Absolutely. Getting those core elements, definition, causes, features, investigation management locked in is fundamental for understanding PWS.
And if you are revising this or other medical topics, do check out passthemsra.com and also freemsra.com. Lots of resources there to help things stick.
Definitely worth a look.
You know, when you really delve into a condition like Prader-Willi Syndrome, it makes you reflect, doesn't it, on that incredibly intricate dance between our genes and our overall health.
It really does.
How these subtle variations at a genetic level can have such profound, widespread impacts on an individual's life and their family's life, too. This is quite something to consider.
A powerful reminder of human biology's complexity and the continuous need for both deeper scientific understanding and really compassionate, tailored care.